As a practicing physician, when a patient comes to you and you've made the diagnosis, can you give some outline on the treatment that would be involved for the patient?
Sure. Let's take irritable bowel, for example. So irritable bowel is abdominal pain or discomfort associated with diarrhea, constipation, symptoms of bloating. Well, the first thing you need to do is, do they meet criteria? And then you start to look at the subsets. Irritable bowel is different things to different people. Some have more diarrhea, some have more constipation. Once you've determined the subcategorization, you can look at treatment options. And there are many treatment options, and it has to be profiled to the individual needs of the patient. You also have to look at the severity of the symptoms. If someone has occasional symptoms once or twice a month that doesn't interfere with their activities, that's a different kind of treatment than it would be if someone has severe, constant pain, unable to go to work, unable to go to school. So in terms of treatments, in the mildest form, you might use probiotics, you might make dietary changes, you might use antispasmodics. Now, once you move up to more severe symptoms, if they're predominantly constipation, you might use fiber, but that can worsen pain. Then you might go to medications that treat constipation. There are agents like chloride channel activators. I mentioned medication specifically, lubiprostone.
Right. Could you give a brief, for the layman, what sort of treatment would that involve?
So if you have constipation, you have to increase the fluidity of the bowel, because with constipation, you're working with slow motility.
Right.
So things move slowly, and the reason why you get constipated is that the stool comes into the colon as liquid, and as it moves along, the liquid is absorbed.
Right.
But if it goes too slow, too much is absorbed, you have constipation. Right. So medications like what's been called PEG solution, Glycolax, Miralax, those kind of medications are agents that increase the fluid of the bowel.
Right.
There are agents that secrete fluid. These are called the chloride channel agents.
Right.
This could be lubiprostone. It could be linaclotide. So that's how we're dealing with the constipation.
Right.
If they have more diarrhea, there are medications like what's called allocetrone, which blocks the absorption, which increases absorption, and you have changed diarrhea to a more normal stool. L-oxacillin, these are agents that can be used. When you have more pain, you can look at antispasmodics, but then you need to move into the antidepressant category.
Right.
Because these are brain-gut disorders, the medications used in psychiatry for anxiety, depression are also used for abdominal pain.
Do you find you have to get across the stigma of psychiatric medication with some patients?
No question about it. If you say to a patient, you have irritable bowel, I want to put you on an antidepressant, that's not the way to do it. From communication skills, the patient will say, I'm not depressed, I'm not crazy. And they may not be. In fact, most are not.
Yeah.
I think that the point you have to look at now is that these, what are called antidepressants, is not the proper term.
Right.
We call them neuromodulators now. They affect the neural system, the brain-gut axis. And so we say to them, you have irritable bowel syndrome, I'm going to put you on a medication that's been called an antidepressant, but we use it differently. Might say aspirin can be used for pain, aspirin can be used to prevent a heart attack.
Yeah.
Different medications have different functions. In the GI tract, we borrow from psychiatry to affect gut functioning through the use of these neuromodulators.
Right. That's an interesting way of doing it. Is there any place for behavior therapy?
Yes, and as I mentioned earlier, we're talking about disorders of gut-brain regulation. Patients who have these conditions become anxious, they become depressed. That anxiety and depression feeds back, it lowers pain threshold, it worsens motility, so they're caught in a vicious cycle. We have patients who won't go out. They'll be afraid, they have to know where the bathroom is. All of those anxieties, all of that focus on their symptoms, we call hypervigilance, selective attention, is modifiable through psychologic interventions. The one that's most recognized is cognitive behavioral therapy, which trains patients to rethink the magnitude or the impact of these conditions.